Like I said, my name is Dr. Aman Upadhyay. I do both anesthesia, mostly do pain medicine, primarily interventional for Henry Ford. I'm pretty much at all their locations, primarily in Dearborn and West Bloomfield, occasionally come downtown. What I'm going to talk to you guys about is Nutraceuticals, which is a blended word, which was actually patented in 1989 by a few physicians from the Innovative Society of Medicine. Pretty much a nutraceutical is a nutritional supplement or a vitamin that can be used for pharmaceutical purposes. So it's not your standard multivitamin. This is more of like high dose, studied medications, even though they're not really medications, like I said, they're supplements. So they're not, a lot of them are not FDA or USDA approved. So that's where you got to be careful in that respect. So we'll kind of talk about some of that stuff as well. Just for background, the reason I became interested in nutraceuticals and was always kind of interested in this was because, as you can tell, I'm from culturally from an Indian background, and growing up in my house, my dad and mom had like a pretty strict regimen. Every morning they would wake up, and one of the first things they would do is, actually it started before they even went to bed. Every night they would take a bottle of water, put it in a copper kettle, leave it out overnight, and then in the morning, the next day, they'd pour it into 2 glasses, put it in the microwave, heat it up. While they're doing that, they would literally eat raw garlic and wash it down with the hot water that had been sitting overnight in a copper kettle. And they were pretty sure that this was going to prevent them from becoming sick when they got older. And believe it or not, it has. Both my parents are in their upper 60s. Neither one of them has ever been on a medication. They don't have high blood pressure, no diabetes. They don't do anything else special that anyone else does. They eat normally. They're not like really strict as far as diet goes. They don't exercise like nuts or anything. So, was it because of that? I don't know. Maybe it's just genes. Who knows? But that's kind of where I always thought, I got an interest behind this and kind of pursued it more when I went into the field of pain. So just pain in general, obviously it's a pretty big topic in just the news in general, not only just in medicine. And I think the reason behind it is because the vast amount of money that's wasted and spent on the resources to take care of patients with chronic pain. I'm not just talking about like disability or the patient's lost wages, productivity losses, the amount of healthcare losses. There were numerous studies, and the most recent one by the Internal Medicine Review Bureau, they actually did a pretty good study where they looked at patients that had either no pain, mild pain, moderate pain, or severe pain. They had 2,000 participants in this study, watched them for 4 years, and they compared their average healthcare cost. And what they found was that somebody that has severe or moderate pain was expending anywhere. They extrapolated these 20,000 patients to the 200-some million people in our country. And what they found was that they were using, on average, anywhere between $560 as a conservative and $650 billion a year, just for treatment, lost wages, losses in productivity. So it's like, staggering amounts of money that are being used on this. And other stuff, obviously, is drug diversion, abuse. Tons of court cases. You hear it all the time nowadays where the number one abused medication in the United States of America is actually pharmaceutical medications. It's not marijuana, it's not heroin, it's not any of those things. And obviously, undertreating pain can result in litigation on multiple fronts. People are really weary, especially I'm sure a lot of you as PAs, NPs, must working in the primary care setting. And just with the recent rule changes in October with the NORCO, a lot of people are just completely afraid to prescribe a medication that they were routinely prescribing before, just because the drug class changed. When in reality, the only thing that's really changed is that you can't put refills on it. You can still give multiple prescriptions at a time that are post-dated, just can't put refills on it. And that's part of the reason they changed that rule, was because of all the drug diversions and the overdoses and all the problems that are going on with it. And obviously, there's always, anytime opioids come up, even as a pain physician, it's a touchy subject. Patients come there and they say, well, I've been on this medication, it works for me, I've been doing good on it for 10 years, but then they've never tried anything else. And the patient's not going to be happy when you tell them, well, you know what, we should try conservative therapy. You just have a back problem, or you just have a knee problem. But they're not going to be happy, obviously, and that can lead to problems. Then there's, on the other spectrum of things, where there's some physicians that know that, it'd be a lot easier when a patient comes in here and complains of pain, just give them some oxycodone and let them go. It'll be a 2-minute visit, and I can see 150 patients a day. And unfortunately, there's a lot of those in Detroit. There was one that was associated actually with Wayne State. I won't mention any names, but he was in Hamtramck, and he actually was busted about 18 months ago, and in a period of 1 year, he prescribed more narcotic medications than the entire Henry Ford health system combined. Yeah, and he was practicing for 10 years, so it didn't, I mean, it's not like, the reason he got in trouble actually was because he had a line out his door for his clinic so long that it was blocking the 2 businesses next door, and they called the cops, and that's when people started getting fishy, like something's going on. So, and this is all real stuff just happening in the community, so this is pretty big stuff. Obviously, more conservative medications like anti-inflammatories, muscle relaxants, they all have limitations. A lot of times people will send somebody, well, this person has pain, just go to the pain clinic, they'll give you a cortisone injection. Well, that's true. A lot of times we do, give cortisone injections, Depo-Medrol injections into joints, into spines. And then there's a role for that, but at the same time, those are not without risks either. Obviously, with interventional procedures, there's an extremely high cost, and especially nowadays with the way insurance companies are, they're more apt to say, well, give this guy some Norco, don't do this procedure that's going to cost $10,000, which might not be the right thing, but you can't really, as you all know, it's difficult to fight insurance companies, and that's something we're all doing on a daily basis to try and do the right thing. And also, along with that, steroids, at Henry Ford, actually, in the orthopedic department, they did a study about 2 years ago where they found that excessive amounts of epidural steroids was leading to cortical deficiency and increased osteoporosis, especially in the hip joint. So those are all things that are known risk, but even more pronounced now so just because of that study that came out. And it's true. I mean, that's why we always limit the amount of steroids that we give anybody in a certain time period just to make sure it's safe and not cause more harm than give somebody a couple weeks of relief, but then, they break a hip 10 years from now. I mean, that's something that you'd have to live with. Other options besides medications. Obviously, there's physical therapy, massage, acupuncture, aquatic therapy. Aquatic therapy is especially good for people who are very debilitated and are not able to participate in land therapy. Problem with a lot of those is there's not a lot of aquatic therapy places in Detroit. We're really limited. Clariford Pavilion has one place. The waiting list last time I checked was about 3.5 months to even get in there. So you refer somebody there, but I mean, it's pretty much a waste of their time and your time to do so. CBT and biofeedback, those have been the most studied alternative therapies. They definitely work. CBT is biotherapy, so cognitive behavioral therapy. And biofeedback is kind of very similar to that in the way that they work. You're kind of reteaching mannerisms. You're trying to get patients to realize that, instead of, like, for example, like in this lecture, one person can be like, wow, this guy's really good at speaker, and the other person can be like, man, this guy's boring as hell. So the goal would be in CBT to get those two people to recognize when they start having those behaviors or thought processes, say they're getting down on themselves or starting to think negatively, to just recognize them and to use some type of coping mechanism to get over that. And obviously that would be directed to pain, not towards me. But hypnotism actually is very well studied. Believe it or not, there's 13 randomized trials with hypnotism, and they've all proven benefit. And those have been for patients with migraines, chronic headaches, low back pain, fibromyalgia. And what they do in hypnotism is they actually do hypnotism on the patients. Then the sessions that actually work for that patient are recorded on a tape and are given to the patient. So when they're having a day when they're having severe pain, or they feel like, this, like especially fibromyalgia, like this is like horrible, I don't know what to do, they will listen to that same session and recall what they did during those sessions, and that's actually been proven to decrease the pain by greater than 50%, which is great, right? But the problem is when I send a patient to CBT or biofeedback, they see the word therapist and neuropsychologist, and the first thing they say to me is, you're telling me I'm crazy, all the pain's in my head? And then you got to try and explain to them, no, that's not what I'm saying, and then usually they run away, and it's like, you're a horrible doctor, you're trying to ruin their lives. And
Or it's not paid for.
Right, yeah, that's another thing too. And especially with the neuropsychology and behavioral therapists, unfortunately, even though like we're as big as health systems as we have pretty limited resources in that area, Unfortunately, in medicine, the way things are nowadays, if you don't bring money in, then they don't really put a lot of money into you. So that's just the reality of it. Traditional medicine supplements, that's what we're going to talk about. A lot of them are not studied, so I'm going to mostly kind of focus on ones that are more studied. There's a lot of them, obviously, they've been out there for thousands and thousands of years. In the last 20 years, things are being studied more and more. It's become more and more popular. I think it was brought on originally by, physicians in India and Europe that were doing a lot of research in this area, and now it's becoming more and more so done in the United States. But I mean, other than pain, the benefits from a lot of these medications include, stroke, decreased stroke, cardiovascular health, dermatology, wound care, wound healing, better outcomes in surgery. So there's a lot of areas other than pain that these things can be helpful in. We're going to kind of focus on pain, though. So nutraceuticals, like I said, hundreds of compounds. We're going to talk mainly about the ones that are helpful. Like saying that, these things are known by ancient civilizations. I'm talking like thousands of years ago. In India, there's something called Ayurvedic medicine, which is pretty popular now because of Dr. Oz. Thanks, Dr. Oz. So he talks about this stuff like all the time on a daily basis on his shows, and pretty much from that, now it's become more popular. Oprah talks about it. Everybody's talking about it, and it's true. I mean, there's actually literature that's been shown from the first millennia that has a 17-page textbook in Sanskrit on how to perform a cataract surgery in India. And we're talking the first millennia. So think about it. I mean, these guys were doing this kind of stuff back then. We haven't really come very far from there to now. One of the most well-known ancient medications was willow bark, which is the original anti-inflammatory. In 1897, Dr. Hoffman, who was a physician and a PharmD, he actually was able to purify willow bark and made it into what's now Bayer aspirin. The reason it became Bayer aspirin was because the company that was funding him was Bayer. And that's how Bayer became a huge company, and they were the first people to have an actual anti-inflammatory on the market. So I think a lot of the people in here that at least have consulted pain in the hospital setting, especially like the neurosurgery colleagues that we have and things of that matter, know that if they're going to consult that I'm on, they're going to know that there's going to be tons of vitamins on the list of my recommendations. Because usually, actually, the neurosurgery is actually pretty good. Neurosurgery and ortho are both good because they've kind of developed to go along with them, especially with vitamin C. And I'll show you why. It's because there's a lot of documented research on both of them for wound healing and for decreasing chronic pain down the road. They also have been shown to decrease opioid consumption. So some of the case reports in this slide, we'll talk about like postherpetic neuralgia, which happens after shingles, which is pretty common. Even though there's a shingles vaccine available, a lot of people aren't getting it, and we see this very commonly in the clinic setting. But not only did vitamin C help, but they were doing massive dose IV vitamin C infusions. I'm talking about like 15 grams at a time over 45 to 60 minutes. And the daily required dose is 70 milligrams, by the way, so we're talking enormous doses. But those things have been shown to decrease VAS scores like on the spot, decrease the incidence of having neuropathic pain. So they definitely work. And in one other study, they actually just didn't treat the patients, but they just checked their plasma levels and found that they all had chronic low vitamin C levels. The reason being, nobody exactly knows why that is. Like, why would a patient that has postherpetic neuralgia have low vitamin C compared to a regular patient? But it's a case in point. This is one of the best studies right here by Kanazi. It was done in Egypt, but what they did was they were giving people 2 grams of vitamin C pre-op, and they were just like we do right now, where we give people like gabapentin or Tylenol or whatever the regimen is. They were just giving them 2 grams, 30 to 45 minutes before they had surgery. They all had laparoscopic cholecystectomies. They're all in the same age group, and what they found was all these people had reduction in opioid consumption that was significant. We're talking 8 milligrams in a 24-hour period, which is a big deal. You're going to decrease the complications from using opioids, constipation, decrease hospital length of stay. It makes a big difference. And this is why orthopedics likes vitamin C now, is because there have been a lot of studies that show that there's a correlation with the amount of vitamin C you give a patient and the incidence of CRPS, which is complex regional pain syndrome, for those of you who are not familiar with it. When complex regional pain syndrome can occur, there's 2 types. One can be when you actually have an injury to a nerve. The other kind can be when you actually have just any trauma. It could be like a wrist fracture. Most commonly happens when people twist their ankle, per se, but you can end up with this chronic pain that is sometimes very difficult to treat. There's no surgery available for it. You can end up with a spinal cord stimulator. You could end up spending like $50,000 and not even have a happy patient, when you could have just spent a couple $100, put them on high-dose vitamin C when this happened, and avoided the whole situation altogether. And Henry Ford's orthopedic department is doing that, so that's good to know. And then it's just more about vitamin C and CRPS. They're doing it 45 to 50 days, which we don't do. Most of these people are only on the vitamin C preoperatively and then during their hospital stay. And we're giving them anywhere between 1,500 and 2,000 milligrams per day. Typically, we order at 500 milligrams with meals. Sometimes if somebody has like a really bad fracture, we'll say 1,000 milligrams with meals. And those are pretty safe doses as long as the patient doesn't have any kidney problems, because it's a water-soluble vitamin. Vitamin D. Vitamin D is something that I prescribe almost routinely to post-op patients, and patients with chronic pain. I don't really prescribe a lot of vitamin C to chronic pain patients just because there isn't a lot of research with it working orally for them, but it's mostly IV infusion. And we're trying to get it approved so we can do IV infusions of it in our pain clinics, but they got to go through all that red tape at Henry Ford, so it's a work in process. So we'll see when that ever happens. But with vitamin D, There's a ton of studies showing that, it's associated with low vitamin D levels and chronic pain, especially low back pain, fibromyalgia, Crohn's disease, pelvic pain. The cause or effect is not really known. It's just known that supplementing with vitamin D can prove to be beneficial. Now, I should actually point out that the reason vitamin D and vitamin C both work is because they're both antioxidants, right? People say antioxidants all the time. Pretty much everything's an antioxidant nowadays. Any vitamin or any fruit or vegetable you eat is an antioxidant. The way these actually work is they actually decrease the amount of free radical oxygen that's in your system. So not only are they going to help with inflammation related to your joints, but that's why they can help with cardiovascular health, peripheral vascular disease, because it's going to help with inflammation at all cellular levels, including in the intima of your arteries and veins. So I'm only talking about the pain aspect, but you got to keep in mind the whole picture. That's why I always tell patients when I put them on this, what's the worst that's going to happen? You might live 5 years longer because you're not going to have a heart attack. Maybe it won't help with your pain, but... So vitamin D case series, this case series was a very small number of people, but the outcome was tremendous. I mean, the people that were on it had significant reduction, and they all stayed on the vitamin D except for one person, and that person's pain came back worse than it was before they started the vitamin D. They've done IM, vitamin D comparisons to placebo. They all help with mortality, mobility, and then there's a big study where in that 70-year-old patient population, the biggest thing was the functional capacity. That's something that we always stress with pain patients. You can't look at a VAS pain score because, supposedly a VAS pain score 10 out of 10 is like somebody's killing you, right? But I mean, every single patient that comes into clinic says they're 10 out of 10. So I mean, obviously nobody's killing them, but it's hard to quantify that. Everyone's different. So the best thing you can do to treat somebody's pain is look at their functional capacity. When they come into clinic one day, the internal medicine doctor, and they're walking with a cane, maybe next time they come in, they're not using that cane. That's good. I mean, then you did a good job. They might say their pain's still 10 out of 10, but that's something you got to ignore. They might not like that, but you got to kind of remind them that, hey, last time I saw you, you didn't look so good, and look at you now, you look great. So, I mean, those are things you got to kind of coach your patients into believing that these things are going to work. That's another aspect of this, and of everything in medicine, right? I mean, the same thing if you put somebody on blood pressure medication. This other study where they did cross-sectional analysis of patients with lumbar stenosis, and they actually found that 75% of them roughly had low vitamin D levels. Yeah?
What kind of cross-interaction do these nutraceuticals have with these patients who are also taking their hypertensive meds, their diabetic meds, their cholesterol meds?
They have almost zero interaction. The biggest thing, like I said, for vitamin D, you can almost not overdose on it. It's impossible. Like the amount of vitamin D you would need would be like, they would have to eat the pharmacy's entire, vitamin D supply, which, I mean, I don't know. There's some crazy people, maybe it'll happen, I don't know. But vitamin C, like I said, 15 grams that they're giving. Linus Pauling, who's won 2 Nobel Prizes in science, he's got the Linus Pauling Institute in Oregon, where they're giving cancer patients, pain patients, Crohn's patients, I said 15 grams. They're giving people anywhere from 15 to 60 grams of vitamin C infusions in 60 minutes. And they've never had any side effects. And they have great results. I mean, the guy won a Nobel Prize, so he must know what he's doing. But yeah, I mean, literally these things are so safe that it's not going to hurt anyone to take them. Faraj did a pretty big study where he pretty much saw the vitamin D supplementation. So he was using 500 units to 10,000 for 3 months. That sounds like a lot, right? Because the daily recommended allowance is, I believe it's 700. It's either 500 or 700, which is like nothing. So that brings another point. So does anyone know how they came up with your daily recommended allowances of vitamins and minerals and things like that? Or when they came up with it? Does anyone have any idea? Has anyone ever wondered that?
It's before the 1970s, before such.
Oh, yeah. So there was 3 doctors in 1940 that were hired by the U.S. government to find out how much of what should we put in these GI troops' meals to make sure that they're going to be able to function and not have problems. So in 1941, they came up with what we still use to this day for the daily recommended allowances for minerals and vitamins. This was based on 3 people's opinion. No studies were done whatsoever. Stuff is starting to change now, but to change that, it's going to be tough because the U.S. Drug Association and the Federal Drug Association pretty much adopted that. So that's why when patients, will say 5,000, international units, like my vitamin thing says I get 100%, I'm only getting 500. Like you're going to put me on huge amounts. Well, that's, I don't ever look at those things. Other than the calories and fat on there, you should ignore everything else that's on there because you're probably not getting enough of what you need. Actually, an example of that would be in 2004, they did a study where they took 17,000 patients and then looked at their food trends over a month to see how many of them were actually getting what's the daily recommended allowance of these minerals. And for vitamin D, it was roughly 43% of them getting 100% of their daily requirement. For vitamin C, it was 51%. For magnesium, it was 40%. Vitamin E, it was actually only 11%. And we'll talk about that. There's reasons why, because we think we're eating stuff that's fortified with these things, but we're not really. It's just all marketing to try and make us feel like we're doing the right thing, but we're not. Mass General did a study with vitamin D deficiency, and they found there was a link with diabetic neuropathy. They also found that supplementing these patients with vitamin D can actually help neuropathic pain. So typically when people come in with neuropathic pain that's like refractory to other medications, just because a lot of the neuropathic pain medications like Lyrica, gabapentin, the stigma when they watch TV, the Lyrica commercial is 15 seconds long and there's 45 seconds of side effects. Nobody wants to be on that, And then like the gabapentin, a lot of patients, they just can't tolerate it. They feel too sleepy or they feel like it's not working because it takes a lot of time. And there's Pamelor. It definitely works, but you get dry mouth. People have crazy nightmares. They can only tolerate so much. They feel sleepy, loopy. So, the simple way to go about that is just put them on vitamin D. Another medication that I'm not going to talk about, but that I put patients on is something called alpha-lipoic acid, 600 milligrams twice a day. You can get it from any GNC. It's about $30 for a month's worth of supply. And it works really well for any neuropathic pain, especially cancer-related neuropathic pain. It's called alpha-lipoic acid. So why does vitamin D work for just about everything? Is because its receptors, vitamin D receptors, are located at that they've studied almost up to 1,000 sites. 1,000 target cells have vitamin D receptors on them. So obviously there must be a reason why they're on everything, and we don't get enough of it. So vitamin D can help with all of these situations: cardiovascular system, nervous system, muscle function, muscle pain, back pain, inflammation, insulin resistance, which is amazing. And this is the way it works, improves the function, it reduces inflammation, like I said, with the decrease in the free oxygen radicals. There's some possible role that it could work at the supratentorial level on decreasing depression. They don't actually know the cause and effect of how that works, but they've done studies with the fibromyalgia patients, and their mood was perceived to be better, and that's kind of how they extrapolated this. So vitamin D, like I said, the recommended daily allowances is saying a small amount, a couple hundred. But the literature, what I tell patients is anywhere from 2,000 to 4,000. It comes in 2,000 international unit capsules from Target, Walmart, Costco, everywhere. It's 2,000. It's a very small gel cap. It's not like one of those horse pills. So it's very small, very easy to use. Take it 2 times a day with your breakfast or lunch and then dinner, and you'll make a big difference. Now, why don't we get enough vitamin D? Do you know what foods have vitamin D in it? Right, so everyone always says milk, but the main thing that actually has it is deep water fish. So you got to eat a lot of deep water fish. Milk, like I said up here, is fortified with vitamin D. So there's 2 types of vitamin D, vitamin D2 and vitamin D3. So what is milk fortified with in orange juice? It's actually D2. What does your body make when it converts sunlight into vitamin D? D3. So that's the natural vitamin D, the one that you want. So when I tell patients to take it, I tell them, make sure when you go there, you look at it and you're getting cholecalciferol, vitamin D3, not D2, which is ergocalciferol. You know how they make ergocalciferol is? They take an ergot moss or mold and they irradiate it. And that actually makes vitamin D2. And that's how they use it to fortify milk. It's not toxic for you, but it sounds disgusting. So, like I said, milk is fortified. So if you wanted to just get the lower end of what I'm saying, the 2,000 units, you'd have to drink 20 glasses of milk to do that. 20 glasses of milk. So to get to 40, you'd have to drink 40 glasses of milk. Nobody's doing that. Not even a kid that likes milk a lot. I mean, even if it's chocolate milk, there's no way you're going to drink that much. But like I said, the other thing is the sun. Like the sun is your best way to convert it. And 30 minutes in the spring or sun, direct sun exposure. You go out there, cut the grass, play outside, do something. You're probably fine. You probably don't need a supplement. Unfortunately, you guys looked outside, and we live in Michigan, so that doesn't really happen over here that often. So pretty much everyone in this room should be taking vitamin D. Next would be omega-3 fatty acids. This is also a very popular topic just because they have so many different health benefits that are available with omega-3s. They can be beneficial for cardiovascular health, as we all know. But at the same time, they can be helpful for joint-related pain, arthritic pain, and it's the same cellular mechanism, decreases inflammation. So there's two essential fatty acids, EPA and DHA. So whenever you buy anything or you look at something that says it's fortified with omega-3 fatty acids, you got to make sure it's those two, because those are the ones that are actually in your body that can be turned into something that you can use. If it ever says anything with ALA, it's not really going to be as beneficial for you because you're not going to be absorbing it as well as something that your body's going to convert. In neurology, they show that it's a good alternative to people who can't take anti-inflammatory medications. So your gastric bypass patients, your clever patients who say they're allergic to everything other than oxycodone and Norco. You can put them on omega-3 fatty acid and vitamin D. They might not be happy, but it definitely works. And you can, quote this, tell them to come see me. But in another study where they give fish oil capsules to non-surgical chronic neck and back pain, they found that most of them did pretty well. 6% did really well. They're using anywhere from 1,200 to 2,400 milligrams. I usually tell patients to take anywhere from 1,000 to 2,000 milligrams. Most of the ones that you get at the store are anywhere, usually they're 900 milligram tablets or they're 1,000 milligram tablets. So just got to take 2 a day. Just take it at the same time you take your vitamin D. This was a really good study on sickle cell patients. I know those are, especially for the primary care people out there or any of the hem-onc people, they're always in chronic pain. And it's hard to know why exactly they're in chronic pain because they're not always in a crisis, yet a lot of that has to do with central sensitization. Chronically being in pain changes your neuroplasticity, and then it changes your whole pain wiring, and then you are in chronic pain. So when they come and tell you that, I mean, it's hard to believe, but it's definitely true, When you got an 18-year-old kid that's telling you he's in pain all the time, he probably really is. He's probably not just BSing you. He's probably telling the truth. So in those patients, this can be very helpful too, and in vitamin D are also helpful. So they're not only going to help with pain, but they actually show significant reduction in things that can cause mortality to these patients. So it decreases their crisis, reduces their anemia, decreases their blood transfusions. So it can be very, very beneficial. And the avascular necrosis of the femoral head was found to be significantly decreased in those patients that were on the omega-3 fatty acids. This is kind of the same thing. This was done mostly for headaches. This decreased the amount of headaches that you're having over the month. It wasn't really decreasing the intensity of the headache. So that's kind of like where it's tough to explain to a headache patient. It wasn't decreasing the intensity, but you're having less of them, and you're having them for less length of time when you did get them. So overall, it was helping, but it's not going to completely take the problem away. But with any pain management strategy, it's, you got to be multimodal. So any little bit is going to make a big difference for you. Cervical radiculopathy, carpal tunnel, these are all neuropathic, or nerve-related injuries. Same thing with thoracic outlet syndrome. They showed a significant decrease in omega-3, or significant decrease in pain with omega-3 supplementation. This study was actually just done about 3 years ago, and it was a pretty well-done study. The only problem is they only had 5 patients in it. They're actually trying to redo that same study at UPenn right now with a larger amount of patients, so we'll see what comes out of that. And then this is unfortunately true. Thousands and thousands of those mice and rats that they use on so many things, you always wonder, what do they do with them? So some pain people actually in Chicago and in St. Louis started using those same mice, and in some cases dogs, and started giving them supplements, giving them different medications to see if they could decrease pain-related behavior and things like that. And they found that it can be helpful and just as beneficial as other medications in development, or preventing the development of hyperalgesia. So a lot of people probably don't know, other than the pain and maybe the anesthesia folks, that there's something called opioid-induced hyperalgesia. That's one of the biggest problems with opioid use. All you have to be is on opioids for about 6 to 8 weeks. That's why we never recommend anybody who has a chronic problem to be on opioids, because you're going to be on it for longer than that. And what happens is your pain medication ends up causing you more pain than you were in beforehand. So I could have pinched that same person 2 months before they were taking pain medication and done so 3 months after they've been on pain medications, and the pain scores would have been drastically different. So this is one of those things that can help offset that from occurring. Other things are magnesium, which is an NMDA receptor antagonist, and the other thing would be gabapentin. There's a lot of literature actually in gabapentin, and that can help reduce that. So if you have patients that you think are going to be on those medications long-term, elderly patients, you should definitely put them on gabapentin, even if it's just a nighttime dose, and then also omega-3 and magnesium. Similar thing here. This is for our arthritic patients. This was actually a pretty big study where they looked at patients who had knee and hip pain. They showed that it decreased NSAID consumption, reduced morning stiffness, decreased the actual intensity of the pain. So while it may not be the single way to treat somebody who has a joint-related pain, it definitely won't hurt to add it on to their Tylenol or their Aleve that they're taking. It can definitely be a little bit helpful. Like I said, I usually do 1 to 2 grams per day. These guys were doing 2.7, but that was the threshold that they felt that in this study you needed to get to do so. But the reason I do 1 to 2 is because there's other studies that show that it could be anywhere between there that could be helpful, especially if you're using it as an adjunct and not like a sole pain reliever. So foods that heal, obviously this is, like I said, these are the other benefits of omega-3s, the triglyceride reduction, decreases Crohn's flare-ups, increases your HDL. So, I mean, all these things are going to be beneficial to the patient along with helping reduce knee pains or whatever pains they may have. These are foods that are high in omega-3 fatty acids. I think most people probably know this. Salmon's your best bet in that route. But, any type of fish is pretty good. But even then, if you look at it, I mean, if you're eating fish on a daily basis, you're still only getting on average about 1.5 grams, So, taking 1 to 2 grams a day is not going to kill you. And then if you continue to do what you're doing here, obviously if you're going to be eating, fish on a daily basis, you got to be careful because a lot of these fish have a lot of toxic side effects nowadays because of the way that they're, they're not really natural. They're grown in farms and things like that. So, you got to be careful. And in that route, there's nothing really wrong with a lot of the supplements because they're pretty safe as long as you get them from the right companies. And typically, if you go to like a Walmart, Target, Costco, they're going to be pretty safe. They're not going to be giving you the ones that you buy from like your massage therapist or something like that, which sounds crazy, but a lot of patients do buy stuff from their massage therapists, their chiropractors. So I'd be careful about that. Magnesium. I really think magnesium works a lot. I actually helped do a senior talk just last week with one of my senior residents in anesthesia about the benefits of magnesium intraoperatively and perioperatively. And there's a lot of research in that route of how much magnesium can help with pain. And it's being used IV, PO, IM. They're even using it epidurally, intrathecally. I mean, you can pretty much put this anywhere you can imagine, and it shows that it can be helpful. And the reason is, like I said before, is it works on the NMDA receptor. There's only a few medications that work on an NMDA receptor. Most of you are never going to prescribe those medications. They're methadone, ketamine, and you're just not going to be out there. Your typical practitioner is not going to be prescribing those medications. Once somebody gets up to methadone, you're probably going to say, you probably need to go to a pain clinic. It's out of my realm of, safe practice, which is not a bad thing to do. But magnesium is one of the only naturally occurring medications or supplements that actually works on an NMDA receptor. And the reason that's so important is because NMDA receptors are important in preventing the opioid-induced hyperalgesia like I was speaking about before, but they also work on pain. Along with that, magnesium is involved in around 300 different reactions in your body. They're very important for anybody who's expecting to be a mom or who's just delivered, for children. And the reason is because they're very important in DNA and RNA synthesis. So it's really, really important in that route. Glutathione production, blood pressure regulation, cardiac rhythm. They can help with diabetic patients. So overall, they can do a lot more good than they will bad. Personally, I not only for pain, but the big route I usually get patients to take magnesium is when they tell me that they have a lot of pain and they say, I can't sleep, doc. Can you give me some Tylenol 3 so I can sleep at night, or give me some Ambien, which I never prescribe anything to help anybody sleep. If I do, I tell them to take 500 milligrams of magnesium citrate 2 hours before you go to bed. And it's actually been proven to be helpful. So not only will it help with pain, but it can help with your sleep hygiene as well. So PO and IV formulations have some analgesic effect. I'm not going to talk too much about the epidural route just because it's probably not in most people's practice here. Plus, it's not FDA approved, so we can't do it. Inadequate magnesium associated with higher risk of sudden cardiac death, stroke, diabetes, migraines. That's a huge one in migraines. At Henry Ford, Dr. Mitzias, he's done a lot of research on magnesium, and a lot of the stuff that I got from magnesium, I learned from him. And he's really well published in giving magnesium to patients to help break migraines and also to help prevent them from recurring. This is more about migraines. They did a study in Italy. They reduced the time for analgesia of Tylenol by 13 minutes. They're getting 400 milligrams a day, which is not a lot. Like I said, I usually tell people 500. The thing about magnesium is you gotta be careful with that too. Just like vitamin D, there's a lot of different magnesiums that are available. The one that you want is mag citrate, and the reason you want mag citrate is because that's the one that's naturally occurring in your body. So you don't want to put something that's not already there out of the system, in the system. Why not use what your body already uses? And mag citrate is also very beneficial because it's more bioavailable. It's absorbed more intestinally than the other mags. That's why mag oxide is used for constipation, because it doesn't really get absorbed a lot. Kind of helps move things along. But this is a good study right here. And they gave IV magnesium to infusion at anesthesia induction. They did this in Germany. They did this for lumbar spine patients. It was good in that they had less opioid consumption, slept better, reported better satisfaction. Only thing that was, obviously could be a confounding factor, especially for the neurosurgery patients, is that your train of 4, possible some muscle weakness, just because they were giving kind of a higher dose of magnesium. But then again, at the same time, there's other studies where they were giving people magnesium and they found no adverse events. And in this study, they were actually giving excessive doses, 16 to 22 grams in 24 hours. So I'm talking like huge doses. Linus Pauling Institute, they give like unbelievable amounts of magnesium to cancer patients, where they're actually having them take anywhere from like 10 to 15 grams of magnesium like Q4 hours until their pain gets better. And they've shown like anecdotally that it works. They don't have any published data per se, but they have a lot of case reports and case series. Other side effects, obviously, when you do this intraoperatively, are intraoperative hypotension, but usually you do okay with that. Obviously, you give huge doses like 16 and 22 milligrams, you might have to worry about respiratory depression as well, because that's one of the late findings because of the weakness it causes. But I mean, that's not, for most of us, not something you worry about. We're going to be giving them orally. You're not going to see these side effects from it. Let's see, 2-week IV infusion and PO improves flexibility, range of motion. This is kind of where, like, I'm hoping in the future at Henry Ford we can use magnesium, is doing IV infusions of magnesium for chronic pain patients and seeing how they do, and then potentially seeing how much of a dose they require, and then kind of put them on oral supplementation based off of that. We're in the process of trying to do that same thing with another NMDA receptor antagonist, ketamine, which has also been shown to be helpful. Obviously, with ketamine, it's a little bit tougher because we can't prescribe it to them. If the infusion doesn't last long enough, we're kind of in a bind because there's only so many things we can put them on afterwards. And magnesium kind of goes along with a couple other supplements, calcium, and the other one's potassium. So magnesium and calcium kind of oppose each other, but at the same time, if you have low magnesium or low calcium, it doesn't offset. It actually will make the other situation worse. So if you are taking magnesium, you should definitely take calcium, and vice versa, because they both kind of work off of each other, and they also have like binding sites for certain reactions, especially for bone resorption. So it's pretty important to use that. Once again, they did some studies with sickle cell patients with magnesium, analgesia for tonsillectomy. Most of the time, these studies show some help, but in some meta-analysis, they're saying that it didn't help with muscle cramps and fibromyalgia. But then there's some other studies out that say it can help with fibromyalgia. Like I said, it's not going to hurt to try. If you put them on it, overall benefit risk, all benefit, there's almost no risk. Yeah. I usually just put them on like a regular calcium supplementation. That's another one of the ones I mentioned, like people are low in. About 30% of people get their daily calcium requirements. So pretty much everyone should be on calcium. But if you actually, in that respect, they're saying that what's considered 100%, which I don't actually know the number off my top of my head, is typically what an average person needs. You would need to drink, I believe you need to drink 8 glasses of milk, no, 7.5 glasses of milk to get 100% of the calcium you need on a daily basis. So nobody's going to be doing that, so you should probably be taking a calcium supplement once you get over the age of 40. Excuse me? Is there an amount of it? Oh, 1,000. Okay, thanks. Yeah, I didn't know how much it was. Thank you. Extra virgin olive oil. This is also another good one, also very popularized by physicians on TV. It's been shown that one of the main ingredients in extra virgin olive oil is something called olacanthal, which is a very potent anti-inflammatory and COX inhibitor. It's naturally occurring in olive oil. It's the main reason that it has the anti-inflammatory effects. That's why they say, the Mediterranean diet. That's pretty much what it's based off of. Is the Mediterranean diet has been beneficial to people that are on it, is because the olive oil that's involved in it can be helpful for cardiovascular health, also for anti-inflammation. That's why they're saying people that live in that area don't have as much pain, live to be longer. And the main reason is because of the olacanthal. People actually studied Olacanthal versus ibuprofen, and they showed that it actually was more potent at inhibiting the COX receptors. So in this study, Beauchamp, he compared it to extra virgin olive oil, and he found that it was considerably stronger than ibuprofen. The dose he was using was 400 milligrams for ibuprofen, though. So typically, patients over here are taking like 800 milligram doses of ibuprofen. So, but still, it's not going to hurt. But at the same time, this especially is one that you can take too much of this, because obviously there's a lot of saturated fats and things in this. Some are good, some are bad, obviously, but in moderation, it's going to be helpful for you. I only got a few more minutes left, so I'm going to kind of go through these pretty quick. But the anti-inflammatory herbs, there's a ton of them. Willow bark we talked about, which is what aspirin's made from now. Ginger is a really good one. Like I said, my parents did the garlic in hot water, and they would also put a lot of ginger in their tea. That's pretty common for most Indian people. Their tea has ginger in it, and that's one of the reasons why it's thought to be that it's so beneficial in drinking chai tea. Is mostly because of the amount of ginger people put in it. It's been used for everything from anti-inflammatory, anti-nausea. It helps with patients with Crohn's disease or any other stomach ailments. Obviously, with these, there are blood thinning factors in these, so you got to be careful. If they're on blood thinners and they're taking, well, most of the time people are on blood thinners, they can't even take an anti-inflammatory anyway. So this might be something you can use instead of ibuprofen or something like that. Devil's claw is actually very well studied, really strong evidence, can help alleviate pain. Yeah, slide in here on that. Turmeric, which is also in a lot of Indian food, very helpful. They're selling supplementations of that where they're pretty much just concentrating it, and it's been shown to be very helpful as well. Very popular in the literature and in the media right now. Quercetin, a lot of people aren't familiar with that. It's actually a flavonoid that's found in a lot of fruits. If anyone's ever had a Monster energy drink, it's in those, believe it or not. But it's actually been shown to decrease the amount of histamine and inflammatory chemicals, helps with immune function, and also can help with pain. Devil's claw, that's what the seed from devil's claw looks like. That's why it's got its name. Typically, though, the part of the devil's claw that you're actually going to be using is the tuberous root of it. It's found in South Africa. A lot of good literature on this, so it's definitely useful. That's what a willow bark tree looks like. Not sure why I put that in there. And then this is pretty much my last slide. So on this, the only thing I would recommend I would really change would be the magnesium. I actually tell people instead of just doing that, nowadays I just tell them to put them on magnesium citrate 500 milligrams, just once a day. Usually, like I said, 1 to 2 hours before they go to bed. And the cost of getting all of these on a monthly basis is going to be much cheaper and much more beneficial to you than all the health problems that you're going to be avoiding down the line. So you'll be helping out, yourself, your family, and everyone really. Any questions? I know I talk kind of fast. It's probably because I drank one of those Monsters. I was telling Kurt yesterday, I was on call last night. I've been up for like 36 hours. Oh yeah, here you can use this.
Somebody was asking about the safety of these, and I can say as a nurse midwife, we use all of these except willow bark and devil claw. And
Oh right, yeah.
Yeah, so the canary and the mine shaft, a pregnant woman with a baby, we do 50,000 of vitamin D weekly. I have found maybe 2 women in the last 5 years that have an adequate vitamin D. We're actually testing on all our pregnant women. Dr. Rao here did a study. We use magnesium for headaches in pregnant women. So there's nothing up there, like I said, other than the willow bark or devil's claw that we don't routinely recommend in our pregnant women.
Yeah, thanks. Any other questions?
Thank you.
Yeah, you're welcome.